Again, thank you guys for interviewing with us. We really enjoyed meeting you. You guys are all great, and I really hope that you guys consider us. Residents, you might want to come sit closer, because this month is dedicated to in-service, old in-service questions, and so I'm going to have you guys take some. So all the residents come sit closer. Piyush, that's you too. We won't ask any of the candidates. I hope you guys enjoyed Shreveport. So we will let Aya take this first case. Don't make fun of the quality. These are some of the. I took a picture from that book. So you are shown an image of the chest from a CT of a girl who is 5 years of age. What is the most likely diagnosis? You can describe what you see and.
So I see cystic changes in the left lobe.
Correct.
I don't see any other institutional disease or any other changes in the other lung fields.
Correct.
Fusions and thorax. So
D is the correct answer. It's CPAM now, congenital pulmonary airway malformation. Congenital lobar emphysema, why is it not congenital lobar emphysema? Because congenital lobar emphysema hates the lower lobes. It's left upper lobe greater than right middle lobe greater than right upper lobe, and it hates the lower lobes. This is lower lobe. Cystic fibrosis. Here are the vessels. I don't see any dilated bronchioles, no bronchiectasis. Pulmonary blastoma is a rare tumor. So the answer is CPAM. CPAM is a hamartomatous proliferation of glandular tissues without alveoli. The blood supply is usually from the pulmonary arteries. Type 1, they have big macrocysts, greater than 2 centimeters. Type 2, they have microcysts, less than 2 centimeters, often with a solid component. And type 3 is very small. It's kind of like infantile polycystic kidney disease, tiny cysts that all look solid because they're so small we can't differentiate it. And they'll excise this because they can increase risk of infection. And anytime you have anything that gets infected frequently has increased risk of becoming a malignant degeneration. The most common, we have congenital lobar emphysema, we have CPAM, we have bronchogenic cysts. Well, often they'll take it out and they'll find a hybrid. That means there's 2 different types, and the most common is type 2 CPAM and pulmonary sequestration. There's a component of both. I told you about congenital lobar emphysema. Left upper lobe greater than right middle lobe greater than right upper lobe. Lower lobe is not good. That's not a good one. Male to female 3-to-1. It's dysplastic immature bronchial cartilages, or it could be due to endobronchial obstruction or alveolar hyperplasia. And it gets huge. It'll shift the mediastinum over. So the most common place is the left upper lobe. Cystic fibrosis, we all know there was no bronchiectasis. That's usually Caucasians, autosomal recessive. They do the sweat test. It's associated with meconium ileus, pancreatic insufficiency, gallstones, focal biliary cirrhosis. They can get sinusitis and hypoplastic frontal sinuses. And pulmonary blastoma is a rare tumor composed of a mixture of immature epithelial and mesenchymal tissues that resemble fetal lung, but they're almost always in an adult. Okay, so pulmonary blastoma, this was a kid. Metastases are very common. 2/3 died within a year. It's marked female predominance. And it's almost, like I said, it's the peak incidence is the 4th decade of life. And there is a thing called pleuropulmonary blastoma, which is in children. It's a very rare tumor, but they said in a retrospective study of 204 children with lung tumors, pleuropulmonary blastoma and carcinoid were the most common primary tumors. Most of the time it's metastasis. So just realize there is a pleuropulmonary blastoma, which is different than a pulmonary blastoma. Pulmonary blastoma is in adults. Pleuropulmonary blastoma is one of the most common primary tumors. It's rare, but because children usually don't get primary lung cancers. Okay, we will let Noor take this one. This is an ultrasound. You are shown a sagittal sonographic image of the pelvis in a 12-year-old girl with pelvic pain. So this is a midline image of the pelvis. Sagittal, head's here, feet here, belly here, back here.
So I see
So sagittal midline in female, what is this going to be?
the bladder.
Okay, bladder. So what's behind the bladder in a girl?
It's the uterus.
Okay, so tubo-ovarian, it could be, this could be a big dilated tube, it could be, but they're usually going to be peripheral, more in the adnexal region. I told you this is midline, and you say uterus is right in the midline. So rhabdomyosarcoma, you think it's a rhabdomyosarcoma? No, it's not a tubo-ovarian abscess. Is this a hemorrhagic ovarian cyst? This is the vagina with blood products, and this is the uterus. So we've got a hematometrocolpos. This is all blood. Usually is an imperforate hymen. It could be due to a vaginal stenosis, and they don't, their blood, their period doesn't come out. It stays in there. So the vaginal canal gets bigger and bigger and bigger and bigger, and then sooner or later it makes the cervical canal get bigger, and the endometrial canal gets real big. And under ultrasound, we had one of these just several months ago, and you could see this blood product going back and forth through the vagina, through the cervix, into the uterus, and then back into the vagina. So this is a hematometrocolpos. Okay, Daniel, a newborn infant has a distended abdomen. This is a contrast enema. It's consistent with what diagnosis?
So you already mentioned contrast enema. There's contrast sigmoid, and there's a small focus of non-dilated segment of bowel, likely a sigmoid distal rectum.
This area right here? Okay. So is this meconium plug syndrome? Is it Hirschsprung's? Is it ileoatresia? Is it meconium ileus?
Well, as far as Hirschsprung's is concerned, I would expect that more distal. With a distal segment, this could be, it's not ileoatresia.
Why is this not ileoatresia? You're correct, it's not ileoatresia. Why?
Because location.
Ileoatresia is going to have, what's the colon going to look like?
Small.
Microcolon. Meconium ileus looks the exact same as ileoatresia
Yeah.
with a microcolon.
Because all meconium is still proximal to that segment.
Because the meconium in the TI obstructed the small bowel, so you have a small bowel obstruction, and you never use your colon, so you have a microcolon. So now, is it Hirschsprung's disease or meconium plug syndrome? You got to know what meconium plug syndrome looks like, and
This could be meconium plug syndrome. I don't think it's Hirschsprung's just because of location. So
but this is the distal bowel.
correct, but look at that segment. Yeah, I mean, I'm guessing you're trying to hint me towards that it's Hirschsprung's, but
In Hirschsprung's, you get a small caliber, and there's an abrupt transition where it goes from small to large.
yeah. So, I mean,
But you can do the same thing with meconium plug, but meconium plug is usually going to be at the splenic flexure. This is not at the splenic flexure. This is near the distal descending of the sigmoid colon. So this is Hirschsprung's. And Hirschsprung's sometimes this real short segment, sometimes this longer segment. Sometimes it's the entire colon. So that was Hirschsprung's disease. Okay, Brad, an ultrasound of the abdomen is shown in a 4-month-old boy. What is the likely diagnosis?
I think I'm seeing the pseudo-kidney sign with the double back.
Or the target sign
Target sign.
of what?
Intussusception.
Absolutely. This is not pyloric stenosis. This is not an ultrasound of the pylorus. This is not a lymph node for lymphoma. This is not the appendix. This is the lumen and then the other lumen inside it. So we've got the wall, bowel wall. We have the intussuscipiens. We have the intussusceptum of intussusception. The intussuscipiens is the distal colon. The innocent septum is the small valve because the ileocolic is the most common. It goes into the colon. This is an ultrasound. This is the target sign. If we put color, we would see color here, and we'd see color here, and that's how we would know it. Very good. Intussusception. Okay. Piyush. This is a newborn, full-term infant presented with severe respiratory distress. You are shown the chest X-ray and coronal and longitudinal ultrasound images of the right and left renal fossa. What's the most likely diagnosis?
So we have a chest X-ray and we have 2 ultrasound images, and they're trying to show the kidneys, but I don't see the kidneys.
Okay.
And what
What is this right here?
Those are adrenal.
Absolutely. This is a normal adrenal. The normal adrenal cortex is black. The normal adrenal medulla is white. So these are adrenals. And you said you don't see kidneys.
Yeah. So Porter's.
Yep,
Okay.
that's it. These are hypoplastic lungs. If the baby is born with pneumothoraces, that's bad. That probably had oligohydramnios. Potter syndrome, we all know, is no kidneys. They have no kidneys. So the students, do you guys know that the amniotic fluid initially was made by the placenta, but later on it's made by the baby? It's baby pee. Placenta is urine from the fetus. Potter syndrome have no kidneys, no urine. So they oligohydramnios. The lung needs, they swallow and they inhale the amniotic fluid. That helps make the lungs mature. This is a small bell-shaped chest. I think there are pneumothoraces, it's just very difficult to see, but this was Potter syndrome. Bilateral dysplastic kidneys, you should have seen maybe some cysts in it. Congenital adrenal hyperplasia, you'd have a big adrenal. This is a normal looking adrenal. Babies you can see adrenals in. Adults very rarely will you see an adrenal, but they'll have kidneys. Horseshoe kidneys, Turner syndrome, this is not horseshoe kidneys, you don't see it. Bilateral pelvic kidneys is possible, but there's no reason you'd have the immature lung. Okay, we're back. Okay, Carson, you can take this one. Regarding the findings in this chest CT, which of the following additional anomalies might be present?
So we have an axial slice through the level of the chest. Looks like our heart is on the wrong side, so dextrocardia. Not sure which syndrome we're going for.
Okay, keep looking at the findings. What is this thing?
PA.
Okay, tell me what do you notice about the pulmonary artery?
Going into
What is this structure? The black?
can't actually see that far.
Sorry. What's this?
We have an artery.
This is black is what? Trachea. And so this is the,
Going behind the trachea, so pulmonary sling.
yes. And so what can pulmonary slings have? Yes, that's the answer, tracheostenosis. This is the main pulmonary artery, gives off the right pulmonary artery, and the left one is coming from the right one, which is the most common of the pulmonary slings. They go between the esophagus and the trachea. So they're gonna, if you do an esophagram, a lateral view of the esophagram is gonna show an anterior impression on the esophagus. And these are associated with tracheostenosis. Pulmonary sling, most commonly, the left pulmonary artery rises from the right. Like I said, it goes between the two. That's very important, go between the two. Aberrant subclavians go behind the esophagus. Aberrant pulmonary or pulmonary sling goes between the trachea and the esophagus. And they're associated with tracheostenosis due to incomplete cartilaginous tracheal rings. There's a thing called Alagille syndrome that's associated with butterfly vertebrae. They can have peripheral pulmonary artery stenosis, but they're not associated with a pulmonary sling. Williams syndrome can be associated with hypercalcemia. They can get supravalvular aortic stenosis, pulmonary stenosis, and mitral valve regurg in Williams syndrome. And the Scimitar syndrome is the hypoplastic right lung with the hypoplastic right pulmonary artery. It's almost always on the right. So, Hunter, what is the diagnosis in this 4-year-old child? You can get closer.
It's good to see it.
Where's the abnormality? Is it the femur or the tibia?
It's in the
It is the tibia. Is it medial or lateral?
It is medial.
Medial. It's this.
Yeah.
And this is genu what?
Verum?
Varus.
Varus.
And for the students, just a quick way to remember, genu valgus is not me, makes an L, valgus. Genu varus is bow-legged. So if you wore valve gum, sticks your knees together, makes an L, that's valgus. This is varus.
I'm not sure what it follows that. I don't, I'm just kind of guessing, but I would say treated rickets maybe, or Blount, some between those.
Blount disease. This is pathognomonic, Aunt Minnie, for Blount's disease. We used to believe Blount's disease was an AVN, now they don't think it is. They think it's due to repetitive trauma. And the varus configuration can get worse and worse. This is not physiologic. You can get, sometimes you can get little metaphyseal beaking, but you're not going to get this deformity, this varus configuration. It's not from previous trauma. Treated rickets, usually they're going to have bow legs, bowed bones, they're going to be osteopenic. The growth plates are normal. This is Blount's disease. Blount's disease, for physiologic genu varus, there's a gentle distal femoral and proximal tibial medial metaphyseal beaking with the apex of the knee joint line. Blount disease has the apex of the curvature along the proximal tibia, and the metaphyseal beaking is more angulated. It's usually bilateral. They can use either orthotics, or they can go in there and cut some of the bone out and straighten it up that way, doing an osteotomy. So this is for Daniel.
So we've got a bare minimum. There's a portion of the sigmoid or rectum looks dilated. Having trouble seeing the descending.
This is descending right here,
Descending.
and this is the transverse colon, cecum. So is this cystic fibrosis? What is cystic fibrosis going to have? Meconium ileus, and that's going to have a what colon?
It's going to have a
Microcolon. So this is not a microcolon, is it?
No.
So that's out. Is this Hirschsprung's disease?
No.
No, because Hirschsprung's, this would have to be smaller than the sigmoid. This is not. So it's not. So you've ruled two of them out.
And as far as an anal rectal malformation, I mean, there's contrast within the colon from the rectum.
So then that leaves
D.
small left colon,
Yes.
which is the same thing as meconium plug, and it's in patients of diabetic mothers can get this. And what happened? This is the microcolon. The left colon is small. The rectum isn't small, but the rest of the small bowel, the left colon, is small, and the transverse colon is dilated. There was a plug at the region of the splenic flexure, and what we use is gastrografin enema. And the reason we use gastrografin is it'll lubricate that meconium plug, and then when we pull a lot of times when we pull the catheter out, this greenish black meconium comes flying out. And it's diagnostic, but it's also therapeutic, because you relieve the plug and you've now stimulated the left colon to become normal. It's small because it was never stimulated, and by us doing that gastrografin enema, we stimulated it, and it will be normal. So this is a small left colon. A lot of times you can just exclude things, and then you get back to one or two, and then you know the answer. So who else is here? We will let, John just showed up. John Boy, a 6-week-old presents with a palpable lump on the left side of the neck. Based on the ultrasound finding, what is the most appropriate next step? So it has this palpable lump on the left side of the neck in this 6-week-old. This is an oblique sonographic image of the left side of the neck. What does this look like to you, John? Left side of the neck. Think about your neck. Touch your neck.
Yeah, brachial cleft cyst.
Okay.
Or is it not?
It's not a cyst. This elongates out. It looks like a spindle shape.
Mhm.
It's an oblique view in the left side of the neck. What runs obliquely in your both sides of your neck?
Carotids, jugulars, sternocleidomastoid.
So, do you know of anything that can happen in the sternocleidomastoid muscle? If you've never seen it, you might not know it. But this is another Aunt Minnie.
Do they have torticollis?
Yes. Yes.
Do they need physical therapy?
Yes. Or nothing. You don't know the name right off the top of your head, but this is fibromatosis coli. It's an Aunt Minnie. This is usually due to like a birth trauma, and it's incidental, but it's worrisome. The mother's freaked out because there's this mass in the head. It's like this, and what you do is you don't need to do an MRI. You don't need a biopsy. It's not an infection. You can do nothing, or you can give physical therapy to try to stretch it out, and it will turn to normal. It will go away, and the kid will be normal. And it'll reassure the mother by telling her, don't worry about it. This is not a tumor. This is not an infection. Everything is going to be fine. So the answer is physical therapy. It's not that, it's rare, but it's not that rare. We've seen several. It's a benign condition presented in the neonatal period as a neck mass. So it's in the sternocleidomastoid muscle. This is replaced by dense fibrous tissue, but then, like I said, after several months, it's normal. So very good. Stretch. You can do nothing, or you can do just stretching. Okay, Nor. You were shown a T1 post-contrast fat sac coronal image of the MR exam in a 3-year-old boy with urinary retention. What is the most likely diagnosis? Yes. Okay. You don't see an enhancing mass? What is this structure? This is pre-contrast, this is post-contrast. Is there anything that turned white? Very good. The most common, this is what organ? The urinary bladder. In a child, in an infant and a young child, the most common bladder mass, if it's not a benign like ureterocele, or it's a rhabdomyosarcoma. When they become older children and in adults, it's transitional cell. If it's at the bladder dome in an adult, if you have a bladder dome mass in an adult, you have to worry that it could be a urachal carcinoma, which is an adenocarcinoma. But all the other ones are usually transitional cell, and this is a fungating polypoid-like, they call it like multiple grates, and it's rhabdomyosarcoma. Metastatic Wilms tumor's favorite place to go is the lung, and then the liver. It's not to the bladder. It's not hemorrhagic. This is a mass that's enhancing. So this is very good. It's a rhabdomyosarcoma. Aya, you are shown 2 images from a contrast CT image of an 8-year-old boy with leukemia who complains of pain after undergoing an upper endoscopy. What is the most likely diagnosis? Here? Here? Yes, ma'am. Is it extraluminal? Interluminal contrast?
I mean, we have, never mind, because we have pure contrast.
Yeah, that would be PO contrast. Okay.
But we have pure contrast, we don't know, so.
But is that a normal shape?
No, probably it's in the wall of the lumen, yeah.
Or it could be in the lumen. So look at your choices. Is this pancreatitis? This is the pancreatic head right here. This is not the pancreatic head. What is this big old thing? It's the same thing as this. He had endoscopy. He has leukemia, had an endoscopy, and now has pain. It's the intramural duodenal hematoma. It's not. There's no free air for perforation. We don't have extravasation of this contrast going out here. It's not pancreatitis. Nobody knows what scleroma is. I'm going to tell you what it is in a second. But that was a duodenal hematoma, intramural so this is pushing on the lumen, and it's causing that crescent shape. A scleroma is a very rare thing. It's a malignant green-colored tumor arising from myeloid tissue. It's associated with AML and CML, and it could occur anywhere in the body, but it has an affinity for the CNS, the bone, soft tissues of the head and neck. It's also been known as a granulocytic sarcoma. So it's really rare. So this is not that rare. We've seen duodenal hematomas. Okay, Bradley, you were shown a plain film and MRI on a 12-year-old boy with a swollen and painful right leg. What is the most likely diagnosis? So what do you see on this x-ray? Very sclerotic. What else?
Is there a little fracture on the?
This is that on the lateral side? No, I don't see a fracture. But this is where the cortex would be.
Okay, is that a periosteal
So
reaction?
periosteal reaction. And what does this kind of resemble? What are the bad types of periosteal reaction? Codman's triangle, the sunburst, and the onion skin. Those are the bad types of periosteal reaction. Does this look benign or malignant to you?
Malignant, that's one of the angles.
Correct. So is this a stress fracture? Heck no. Stress fracture is usually in the mid shaft. Is this a Brody's abscess? Abscesses are the one. Osteomyelitis is the one thing that can look really nasty, like a tumor. Is this an osteoid osteoma? What would an osteoid osteoma look like?
Those are round.
They're a round nidus, a lytic nidus with thickened cortex, but it's not going to do all this stuff, and you're not going to have periosteal reaction. So we got it down to is it Brody's abscess or osteosarcoma? Is this like going outside the bone with abnormal? So what do you think it is?
It's in the location you'd expect an osteosarcoma. It's got the periosteal reaction like an osteosarcoma, right age group. Going with the.
And a Brody's abscess is more of a chronic type of abscess, correct, Alberto? And they're going to be more well circumscribed. It maybe have your body have a chance to get sclerosis around it. And so this is an aggressive lesion. This is an osteosarcoma. The most common primary bone tumor in a child is osteosarcoma. The most common primary bone tumor in an adult is multiple myeloma. The most common bone tumor is metastasis. That's secondary. The most common place for an osteosarcoma is the distal femoral metaphysis. The number 2 spot is the proximal tibial metaphysis. The number 3 spot is the proximal humeral metaphysis. There was one word in common in all of that, and that's metaphysis. Osteosarcoma loves to be metaphyseal. MRI will often show you much more involvement in the marrow than you can see on an x-ray, and it'll show you all kinds of soft tissue component. So yeah, this is not good. It's an osteosarcoma. Okay, Carson. We've got these two, and I've got one more image to show you.
Axial and sagittal MRI of the level of the pelvis or acetabulum bilaterally, sacral to the midline. We have a mass involving the posterior elements and central elements of the spinal cord. I mean, of the vertebral column.
So here's the sacrum, here's the coccyx. So it's anterior to it. Let me show you another one.
Okay. So
This is a 13-month-old girl with this pelvic mass.
T2 fat sac, is that what it says?
This is incorrect. What's the most likely diagnosis?
Sacrococcygeal teratoma?
Absolutely. You know, 4 types of sacrococcygeal teratomas, and which one's the worst prognosis? Okay, it all depends on where it is. Type 1 is all external, so there's no doubt they're going to see this huge thing and they're going to take it out. Type 2 is when its majority is outside, but there's some inside now, inside the patient. Type 3 is when the majority is inside the patient, there's only a little bit on the outside, and type 4 is when it's all inside. And this is the worst prognosis because it's all inside. It can go unnoticed for a while. It can degenerate into a malignancy. And what piece of spine bone do they take out on every one of them? When they take this out, they take the coccyx out. The coccyx comes out. If it's involved in the sacrum, they'll take the sacrum out. But this was a sacrococcygeal teratoma. Type 1 completely outside, type 2 mostly outside, type 3 a little bit outside but mostly in, and type 4 is completely internal. Coccyx is removed always to prevent recurrence. If left in place, the risk of tumor returning is about 40%. All tumors are sent to pathology to determine if there's any cancer in it, and they're usually diagnosed in the newborn period. Okay, this is a hard one to see. It's small, but well, John, you can take this one. 3-year-old has abdominal pain, ultrasound was performed. What is the appropriate management? Sorry that the images are dark. But what is this and what is this? Transverse longitudinal.
So, Gracie, on the transverse longitudinal right lower quadrant, there is a brain structure that's hyperechoic with central hypoechogenicity. I'd suspect with the history and the images that maybe that's an inflamed appendix, and maybe they need to have a...
Okay, what if I told you there's this echogenic on the outside and hypoechoic and echogenic and hypoechoic?
Maybe intussusception.
Correct. This is the pseudo-kidney sign and this is the target sign. So what's the appropriate next step?
Going to be a therapeutic enema.
Correct. Pediatricians, you need to let them know. They need to have an IV in this kid. The surgeon has to know about this patient. You can use air. If you use air, you go more than 125 millimeters of mercury. And if you go really fast, you can pump fat. They have that cutoff valve, but if you go real fast, you can go higher than 125. If you go higher than 120, 125 millimeters of mercury, you can perforate them, or you can use water soluble. And the ACR, they'll tell you can use it, whichever one you're more comfortable with. You don't use barium. If you use the air, if you use air reduction, you have to have a big syringe and a big needle ready, because if you perforate them, they're going to get a pneumoperitoneum and a tension pneumoperitoneum. And that needle, you'll go in the midline above the belly button, put it in the midline to get rid of that tension part, and it all out. And surgeons have to know about it, because if we perforate them, they have to go to surgery, or if we can't reduce it, they have to go to surgery. So they have to know about it before. If they don't know, if we do the study and we perforate them and the surgeon didn't know about it, the pediatricians and us, we're in a lot of trouble. Okay, Piyush, you were shown a post-void radiograph from a VCUG, so it's a post-void performed on an infant. The Foley catheter is in the bladder.
So we have a single radiograph showing severe bilateral hydronephrosis, worse on the left side compared to right. There's bilateral hydroureter as well. And the choices are megachelicosis, chelicea diverticular, posterior urethral walls, and nephroblastomatosis. I'll go with choice A.
Okay,
Posterior urethral walls is the most common cause of bladder outlet obstruction in male infant. So I'm trying to see how. Sorry, you were saying something.
Okay, in megachelicoses, these are huge. They're increased number, but the rest of it is normal. The pelvis and ureters are not big.
Okay.
And so this was a VCUG. So how did this contrast get here? It refluxed. And this is like a forniceal rupture. So this has been a long time. This thing has been obstructed. So these are not calyceal diverticula, you would see contrast, but no reason to have reflux. There's no reason to have big ureters and tortuous ureters. Nephrolystomatosis is a subcapsular masses in the kidney, has nothing to do with the collecting system. So this was a patient with posterior urethral valve. And the bladder's small because it's been working over time to try to get the urine out. So that was a posterior urethral valve. Megacolicosis is non-obstructive dilatation of the renal calyces due to malformation of the renal papilla. And this is an example. You have huge calyces, increased number, but the ureter and the pelvis are not big. Okay, Hunter, 15-year-old girl, 6 days post-laparoscopic coli, presents with severe abdominal pain, and this is a petabiliary scan. What's most likely diagnosis?
So I'm not seeing any type of tracer move from the liver down through the common bile duct or anything like that. I think this is probably some type of like stricture or maybe the naked common bile duct or something along those lines. It's hard to see.
So what is this?
It looks like possibly leak.
Okay.
I can't.
So it's a bile leak. They picked it when they operated. It's not a colodocal seal. It's not sphincter spasm. It's not a stricture because it's not like it is a dilated common bile duct, common hepatic duct. This is a leak from when the surgeons nicked it. Okay. We will let Daniel take this one. This is the just inspiratory chest X-ray. This is left lateral decubitus, and this is right lateral decubitus.
So they're doing this to evaluate one body.
Correct. Correct.
They put the patient on his left, and then the right got hyper expanded.
Correct. And this one got what?
Lower volume.
Gets smaller.
Yeah.
And then they put this on this side.
And then they're about equal.
Okay. So
I believe there's an obstruction or a foreign body.
on which side?
Right.
Correct. Look at this. The initial chest X-ray, this is more lucent. Normally, this diaphragm is a little bit higher than this one. This one's a little bit lower. This is more lucent than this lung. Here, when this side got real big, this side got normal. What you do is if you have a ball valve mechanism, you put, if you're normal, like right now if I did a decubitus both on me, my side that's on the lower part, the decubitus part, the lower part is smaller, the upper one gets bigger. Then you flip them and that one gets smaller and that one gets bigger. In this case, with the foreign bodies on the right side here is up, it got big. But when they switched them, the right side doesn't get smaller. This is on the dependent portion. This should have got smaller. So the foreign body is in the right main stem bronchus. So that is absolutely correct. Aya, you are shown 2 single-shot fast spin echo images from an MRI of a 22-week fetus. What's the most likely diagnosis? This is the baby's head, the brain. The kidneys are massive. So is this a posterior urethral valve? Will posterior urethral valves cause the kidneys to be big? It will cause dilatation, obstruction, reflux. So no, that's not a good choice. Is this a multicystic dysplastic kidney? You don't see any cysts. Multicystic dysplastic kidney is going to have huge, various sized cysts. Is this autosomal recessive polycystic kidney disease? Okay, what about bilateral UPJ obstructions? It has to be C because there's no obstruction. These autosomal recessive polycystic kidney disease, also known as infantile polycystic kidney disease, they have too numerous to count 1 to 2 millimeter cysts, microcysts. So what you're going to see on the ultrasound is you're going to have a very enlarged echogenic kidney. You can't see these cysts because they're only 1 to 2 millimeters. On MRI, you're going to have the kidneys are going to be huge, and remember this has two different ways they're going to either die of one thing or they're going to die later on of another thing. For autosomal recessive, they're either going to have bad kidneys or they're going to have bad liver, correct, periportal fibrosis and stuff. So if the liver disease is real bad, the kidney disease won't be bad. If the kidney disease is bad, the liver disease won't be very bad. And that is what. Would they have oligo? They could. They could. They don't have to. No, but they could. Autosomal dominant, they will later on get renal failure. These little babies are going to die either of renal failure or hepatic failure.
The dysplastic kidney should be small too, correct? Aren't they
Well,
small?
in utero, you would see big cysts. What happens is later on in life, it shrinks down to nothing. Okay, Nor, you were shown this axial T1 image of a term newborn. What? There's no holoprosencephaly, and that's is it heterotopia, lissencephaly, schizencephaly, or hemimegalencephaly? What'd you say? The answer is lissencephaly. This is a slick brain, a figure 8. There's no sulci. This looks like a figure 8. There's no sulci. In a full term, there better be sulci. Usually their sulci are developed by 28 weeks of gestational age. So if the kid is really preemie, you might not see it, but even afterwards you might not see it. But in a full term, there should be sulci. Schizencephaly is a hatchet-shaped defect. There's a closed lip schizencephaly and an open lip schizencephaly. And what it is the open lip, this abnormal gray matter would go into here, and then there would be abnormal gray matter here, and there would be a black space, like a hatchet went in there. Closed lip is when the abnormal gray matter is touching each other. So it would be like this, but it's abnormal gray matter. These are all migrational disorders. Heterotopic gray matter is when you have this gray matter where it shouldn't be. You might see an island, and you might see little nodules around the ventricles. You might see in the deep white matter, you might see gray matter, and it'll enhance the same as gray matter. On any MR sequence, it'll be the same. On ultrasound, it'll be the same. CT, it'll be the same. But this was lissencephaly. Here's some questions that are in services. This is for John. Which of the following is an absolute contraindication to an enema reduction of intussusception? Absolute contraindication. No, there's no time limit. The longer it's there, the less likely we can reduce it. But if it doesn't have one of these other signs, we can try.
Peritoneal sign?
Yes. If it's peritoneal signs, that means it's perforated. And why reduce something that's perforated when they're going to have to operate and find that hole? Because they're going to have to reduce it themselves and then cut out the bad part. So peritoneal signs. If we see free air on an abdomen X-ray, we don't do the study. Ascites is worrisome because did they perforate? But if we don't see, if the surgeon said it's not an acute abdomen, there's no rigid peritoneal signs, and there's no free air, we can do it. The longer it's been obstructed, the longer they've had this, the harder it's going to be for us to reduce. There's going to be more edema, but that's not a contraindication. Absolute peritoneal signs is. This is a tough one. This is for a senior.
On the last slide, what was the bottom part?
about high-grade obstruction may indicate a longer time of interception and lower the chance for reduction, but it's not an absolute contraindication. So there's no, don't say if they've had it for more than 24 hours, we can't do it, because we can. So, Piyush, regarding transposition of the great vessels, which of the following statement is correct? This is this is the hardest of all the congenital heart defects is transposition. And there's two types, a D type and an L type. So in D transposition, is the aorta connected to the morphologic left ventricle?
No, it's incorrect.
That's false. That's correct. The aorta is connected to the right ventricle. In D transposition, is the right atrium connected to the morphologic left ventricle?
I'm not sure. One of these is a corrected one. The other one.
L is the corrected one.
Right. So that would make this that would make statement B incorrect.
Incorrect. That's correct. In D's transposition, the uncorrected one, the right atrium is connected to the right ventricle, not the morphologic right ventricle. In L transposition, the aorta is connected to the morphologic left ventricle.
That is incorrect.
Okay. In L transition, the right atrium is connected to the morphologic left ventricle.
That is correct.
Very good. The answer is D. That's correct. So in all types of transposition, the aorta is connected to the morphologic right ventricle. So the pulmonary artery is connected to the morphologic left ventricle. And if that's all you have, and there's no PDA, there's no ASD, there's no VSD, you have two circuits going that are not communicating, the baby has to die. So what they would do is they would either give them the stuff to keep the PDA open, or they would do a balloon septostomy of the atrium to make an admixture. In D transposition, the right atrium maintains its normal connection to the morphologic right ventricle. In L transposition, also called corrected, because there's no surgery, it's more corrected. There's ventricular inversion, so that the right atrium is now connected to the morphologic left ventricle, which is giving off the pulmonary artery, okay? And the left atrium is connected to the morphologic right ventricle, which is giving off the aorta. So it's kind of like it got corrected, but you see what I'm saying? This is very difficult. But you are correct. You get the correct answer. A lot of times you just have to kind of go through the answers and think about it and say that was wrong.
There is a mnemonic also. L is for lives and D is for dies. That's what I forgot and I was trying to recollect. That's an easy way to remember.
Good. We will give this one to Daniel. Which of the following is considered an appropriate indication for fetal MRI? Verification of fetal gender and dating. We do MRIs for that.
No.
If we do, Medicare, Medicaid, they're not going to pay us anything because we're going to do an ultrasound for that. Determination of twin amnionicity.
I think that's
Measurement of fetal lung volumes.
we could do that with ultrasound also. So it's weird.
Evaluation for anomalies associated with gastroschisis.
I'm going B or D.
Okay. This is usually ultrasound.
Yes.
What associations are there with gastroschisis?
Cardiac.
No. Omphalocele, yes.
Oh.
Omphalocele is the midline one with the membrane, the cord inserting the membrane. You always ask the medical students, would you rather have an omphalocele or gastroschisis? And all medical students say omphalocele because it has a membrane. No, you don't want that. 50 to 75% of those have chromosomal abnormalities, heart problems, all kinds of problems. Gastroschisis is usually on the right, small little defect, small bowels herniating out, and they may have atresia of the bowel. That's it. There's not going to have anything else but maybe bowel problems, bowel atresia. So fetal lung volumes is a possible to make sure that if they want to, if the woman is like her water broke, they can do a fetal MRI and say we can't deliver this baby. The lungs aren't mature yet. I don't know how you do it because I've never done one, but that's the answer for this question. And this is the thing. This is a tough one. Carson, trigonencephaly describes premature close of which suture? What do you get when you get premature closure sagittal suture. When you have a sagittal suture, now the head can't get this way because this is closed, but it can get this way. So you have a big, long, thin head. So you get dolichocephaly. On the coronal suture, this is fused, so now the head can't grow in this way, but it can grow this way. So you get a short, wide head. Brachycephaly. What is a metopic suture? It's in the frontal bone. Normally it's just this. And if that fuses, you can get weird shaped trigonencephaly. Lambdoids gives you plagiocephaly if single-sided, or tetracephaly if bilateral. You get a real flat back of the head. But most common is dolichocephaly, that's the sagittal. We're just looking at it this way. This is where the sagittal is. So now the skull cannot grow in this direction, cannot grow this way, but nothing's stopping it from going this way. So you get a big, long, thin head, dolichocephaly. Coronal stops it from going this way and that way, but it doesn't stop it from going this way. So you have a short, big head, brachycephaly. Okay, Nor. What is the most common cause of medullary nephrocalcinosis in the neonate? That is a cause of, all these are causes of renal tubular, of medullary nephrocalcinosis, but in the neonate, think about the NICU, what they give to the NICU when we see it in the NICU babies. Diuretics. Is that what you said, Lasix? Yes, diuretics. That's exactly right. Diuretics is the most common cause in the neonate. Milk alkali syndrome, you drink a whole bunch of, you get a bunch of calcium. In ICU, they use Lasix. Oxalosis is an inborn error of metabolism. It's not very common, and it's in the differentiation for both. Out of medullary nephrocalcinosis or cortical medullary nephrocalcinosis, which one's by far the most common? Medullary or cortical? It should have been a T here. No, cortical is only like 10%, 15%. Medullary is 85, 90%. Okay, Dan, regarding total colonic ganglionosis, which of the following statements is true? So this is, we're talking about total Hirschsprungs. Are there skip areas of involvement may be present? Boys are affected more commonly than girls. A positive family history is uncommon, or it can involve the terminal ileum.
I mean, just test taking skills, I want to say D.
That's the answer. Okay, and think about total aganglionosis. Total Hirschsprungs is just like ulcerative colitis. Are there skip lesions in ulcerative colitis? No, it starts at the bung and it works its way proximal. There's no skip lesions. Ulcerative colitis goes from tongue to bung and has skip lesions. You can't have no myenteric plexus or Auerbach's plexus, then have some and then don't have it. It's continuous. In short segment Hirschsprungs is more common in boys. Total aganglionosis is equal. A positive family history, if you have a positive family history of total, you might have total. So, and it can involve the terminal ileum. Just like ulcerative colitis can get backwash ileitis through the ileocecal valve to cause that. So the answer, you were correct. Your test taking skills are good. D. Always continuous. Boys 3 times more common in short segment, but equal in total. Strong family history in total. And the TI is involved in about 3% of the cases. Okay, John Boy. Regarding juvenile polyps, which of the following is true? They are more common in the cecum. They are typically greater than 5 centimeters in diameter. They do not develop into cancer. They are most common in children less than 1 year of age. Juvenile polyps.
I'm not really for sure. A.
Okay, does juvenile polyps, are they adenomas? Or are they just hyperplastic polyps? They're just hyperplastic polyps.
Okay.
So what are those? Do they turn into malignancy?
No.
No, they do not turn into cancer. Juvenile polyps are more common on the left, like the rectosigmoid colon or the descending colon. They're usually smaller. They don't turn into cancer, and they're usually a little older kid. We did that enema, that intussusception on that one that had colonic intussusception. She was like 5. She had a juvenile polyp in her near her splenic flexure. So the answer is C. They do not turn into cancer. Okay, this is a tough one, Piyush. Regarding neonatal renal vein thrombosis, which of the following is true? Is it usually bilateral? Is it associated with maternal sarcoid? Does it extend centrifugally from the hilum? Or could it result in renal atrophy?
Neonatal renal vein thrombosis. Oh, it may result in atrophy.
Absolutely. That's the answer. That's test taking skills. Correct. No, that's true. And that's what a lot of this is. These are tough. But just, we're going to go over it. It's usually unilateral. It's usually on the left. It's associated with maternal diabetes, not maternal sarcoid. It goes from the periphery towards the hilum, not the hilum peripherally. So the answer can result in atrophy. After resolution, there's a variable degree of renal atrophy and involution. So, very good. That's for the interviewees. That's what the in-service tests are like. They're tough. They're tough.
The images are really good.
But what Daniel said is a lot of times you have to work through those answers, delete answers are false, and then maybe you can have good test taking skills and get it. And in the old days, we'd take the writtens, and then we'd go take an oral. There are no test taking skills for that because orals are orals. We're talking. I would rather take that than take a written test because how many times have you gotten the answer down to 2? And you have a reason why this one's good and you have a reason why this one's good. If we were talking and you were explaining both of those to me, even if you chose the wrong one, you explained it good, why both, I would pass you. Here, you're going to guess the wrong one and they're going to think you have no idea of anything about that. So, because that's all the core exam is all on the computer written, answer A, B, C, D, and the certifying exam same way. There's no oral exams anymore, which I think most program directors don't like it. And the reason they do it is because it's a lot cheaper for them because they have to get all these examiners in here for this whole week long. But I don't know. Our residents do very well, which is wonderful. And so thank you people for interviewing. I hope you enjoy Shreveport. Please really consider us. We are a very good program. We're a family. You see, did I get mad when they didn't get the question right? We don't get mad.
He usually brings his paddle out.
The lashings come after y'all leave.
Yeah.
You gotta wait till you leave, and then they're gonna take extra call. They're gonna take extra call. And like I think I told every one of you guys, this Dr. Simon's he's the best program director we ever had. He cares about these people. He cares about their education. He really does. He cares about our patients. He cares about this program. He cares about each one of these residents. He wants them to be the best radiologists they can be. He wants them to be board certified. And he wants them to be out in private practice doing well. And people say, where are you from? And he says, I trained at LSU Shreveport. Because that all looks good for us. Because we need you to be board certified. We need you to pass. We need you to be good because we don't want you putting a dark cloud over us. And so we really, it's a symbiotic relationship. We need you and you need us. So welcome to Shreveport. Please consider us. And thank you.